Hi everyone, welcome to MSP. I am Dr. Avijit. Today we are going to discuss basic facts of CNS gliomas. Gliomas are of two important groups, diffuse gliomas and circumscribed astrocytic gliomas. Diffuse glioma has two types, adult type and pediatric type. Pediatric type will have two groups, low-grade gliomas and high-grade gliomas. On the other hand, adult-type diffuse gliomas include three tumors, astrocytoma IDH-mutant, glioblastoma IDH-wildtype, and oligodendroglioma IDH-mutant 1p19q co-deleted. Pediatric type low-grade gliomas include diffuse astrocytoma, MEB or MEB11 altered, angiocentric glioma, polymorphous low-grade neuroepithelial tumor of the young, PLN2Y, and diffuse low-grade glioma, MAP kinase pathway altered. Whereas pediatric type high-grade gliomas include diffuse midline glioma H3K27 altered, diffuse hemispheric glioma H3G34 mutant, diffuse pediatric type high-grade glioma H3 wild-type and IDH wild-type, and infant type hemispheric glioma. And the second group, that is circumscribed astrocytic gliomas, will have pilocytic astrocytoma, high-grade astrocytoma with piloid features, AGAP, subependymal giant cell astrocytoma, SEGA, pleomorphic genitouroastrocytoma, PXA, chordoid glioma, and astroblastoma MN1 altered. Now let's dive into the basic features of individual type and subtypes. Let's see the salient features of adult-type diffuse astrocytoma. The first one is astrocytoma IDH-mutant. Diagnostic criteria include a diffusely infiltrating glioma, IDH1 or IDH2 mutation, lack of 1p19q co-deletions, or nuclear loss of ATRX or A2RX mutation. It has three subtypes designated as various grades like astrocytoma IDH-mutant, CNS WHO grade 2, grade 3, and grade 4. They most commonly develop in supratentorial compartment, generally within frontal lobes. IDH-mutant astrocytomas are generally associated with younger age with longer survival. The term glioblastoma is no longer applied to the grade 4 IDH-mutant astrocytoma. CNS WHO grade 2 tumors, they are composed of well-differentiated fibrillary glial cells with mild to moderate increased cellularity, mild nuclear atypia. Nucleoli are typically indistinguishable. Mitotic activity is absent or rare in grade 2 tumors. Remember, the term gymnostocytic astrocytoma is typically an IDH mutant astrocytoma where gymnostocytes account for more than 20% of the tumor cells. CNS WHO grade 3 tumors, they often display increased cell density with greater nuclear atypia, sometimes may be associated with multinucleated tumor cells and atypical mitosis, but microvascular proliferation and necrosis, features of grade 4 tumors, are absent here. CNS WHO grade 4 tumors, they must have necrosis and or microvascular proliferation, most importantly, homozygous deletion of CDKN2A and or 2B, warrant a diagnosis of grade 4 tumor even in the absence of above two morphological features. Glioblastoma IDH wildtype. It's a common tumor accounting for 15% of all intracranial neoplasms and about 50% of all primary malignant brain tumors in adults. Generally affected older adults with peak incidence between 55 to 85 years. It is characterized by one or more of the following histogenetic features like microvascular proliferation, necrosis, TERT promoter mutation, EGFR amplification, chromosome 7 gain, and chain loss. It's notorious for its invasions of neighboring brain structure. The tumor is composed of usually poorly differentiated cells with marked pleomorphism along with brisk mitotic activity. Characteristic diagnostic features are microvascular proliferation and necrosis with or without perinecrotic palisading. Tumor may be morphologically heterogeneous, however, better differentiated neoplastic astrocytes can be discernible at least focally. Some glioblastomas have well-recognized patterns. Giant cell glioblastoma. They may be distinctive because of their circumscription and breach in reticulin, generally not associated with a more aggressive clinical course. Perivascular accumulation of the tumor cells may form pseudo-rosette-like pattern. Gliosarcoma is a rare, accounting for 2% of glioblastomas. They are often a well-circumscribed mass due to high connective tissue content. Sarcomatous metaplasia is common in IDH-wildtype glioblastoma, then IDH-mutant astrocytoma. Sarcomatous component commonly demonstrates pattern of a spindle cell sarcoma. Tumor may show alternating areas of reticulin-poor glioma and reticulin-rich sarcoma. Prognosis is very poor as compared to classic IDH-wildtype glioblastoma. Epithelioid glioblastoma, they are usually well-demarcated tumor characterized by loose aggregates of large epithelioid to rhabdoid cells, often mimicking metastatic carcinoma or melanoma. GFAP and OLIC2 often help to distinguish glial lineage. Small cell glioblastoma. They are composed of cells with monomorphic small round elongated hyperchromatic nuclei with mild nuclear atypia but with brisk mitosis. Morphology may resemble anaplastic oligodendroglioma, but the small cell glioblastoma is uniformly IDH wild-type. Glioblastoma with primitive neuronal component. Here the primitive foci are sharply demarcated from the adjacent glioma and show high cellularity, anaplasia, mitotic activity, and homarite rosettes. Diffuse astrocytoma part displays GFAP expression, while the primitive areas have positivity for cyanoptophycins and a high Ki67 levelic index. Granular cell glioblastoma. Aggregates of large cells with granular cytoplasm can mimic a granular cell tumor. Typically, they have an aggressive glioblastoma-like clinical behavior. Tumor cells are OLIC2 GFAP positive. Unlike other glioblastoma, they often show EMA positivity. Oligodendroglioma IDH-mutant 1p19q co-deleted. Another diffusely infiltrating glioma with two subtypes, oligodendroglioma IDH-mutant and 1p19q co-deleted CNS WHO grade 2 and grade 3. About two-thirds of the patients manifest with seizures. Oligodendroglioma presents with the median age of 43 years at diagnosis. Calcification is frequent in these tumors. Contrast enhancement can be seen in more than 70% of grade 3 oligodendroglioma, whereas it is less than 20% in case of grade 2 tumors. Tumor cells manifest uniform round nuclei with salt and pepper chromatin. In FFP tissue, clear cytoplasm often creates an artifactual honeycomb or fried egg appearance. Gliofibrillary oligodendrocytes that display a thin perinuclear rim of GFAP positivity are more commonly seen in grade 3 tumors. Microcalcifications are frequent within the tumor. Oligodendrogliomas typically show a chicken wire-like dense network of branching capillaries. Occasionally, perinuclear and perivascular satellitrosis can be encountered. Although there are no well-defined criteria for distinction between tumor grades, certain features may suggest higher grade like high cellularity with marked cellular cytological atypia, brisk mitotic activity, necrosis with or without palisading, and microvascular proliferation. Brisk mitotic activity indicates more than 2.5 mitosis per square millimeter, equating to greater or equal to 6 mitosis per 10 hyperfield of 0.55 mm in diameter and 0.24 square millimeter in the area. Let's move on to pediatric type diffuse low-grade gliomas. Diffuse astrocytoma MEB or MEB unaltered. It's a CNS grade 1 tumor, it's a rare tumor and typically presents with drug-resistant epileptic seizures. The tumors have an indolent behavior. Mostly gross total resection of the tumor is curative. Tumor is composed of monomorphic glial cells diffusely arranged in a fibrillary matrix or permeating neutrophil. Individual tumor cells are having blunt, round to ovoid to spindle nuclei. Mitotic activity is typically absent or low, as well as no microvascular proliferation or necrosis. Angiocentric glioma. It's a CNS WHO grade 1 tumor. Patients with angiocentric gliomas typically manifest with chronic intractable partial epilepsy. Most of the tumors are associated with MEB QKI gene fusion. The tumor is composed of uniform bipolar spindle cells oriented around blood vessels in the form of rosette-like pattern or as monolayered or multilayered sleeves. Spindle cell areas can have variable density ranging from tight interlacing fascicles to compact schwannoma-like appearance. Myxoid and macrocystic areas may be conspicuous. Polymorphous low-grade neuroepithelial tumor of the young, PLN2Y. It's a CNS WHO grade 1 tumor. PLN2Y are associated with seizures in young individuals. The tumor usually have oligodendroglioma-like features, including small round nuclei, perinuclear halos, delicate branching capillaries. Astroglial components may display spindling and more conspicuous atypia without mitotic activity. Calcification can be seen in large majority. PLN2Is are positive for GFAP, OLIG2, and CD34. BRAF positivity can be observed in a subset of tumors. Diffuse low-grade glioma, MAP kinase pathway altered. These tumors are IDH-wildtype and H3-wildtype. They lack homozygous deletion of CDKN2A. Despite diffuse nature, the tumor seems to have a better outcome. The WHO grade hasn't yet been assigned for these tumors. Tumor cells have bland appearance with a relatively low density. Mitotic activity is rare or absent. There is no microvascular proliferation or necrosis. Its subtypes can have distinct morphological features. In diffuse low-grade glioma with FGFR1 alteration, the morphology resembles an oligodendroglioma. Tumor cells display diffuse OLIG2 positivity and variable GFAP positivity. Unlike PLN2Y, CD34 positivity is restricted to a few cells only. In diffuse low-grade glioma, BRAF mutant, the tumor cells are well differentiated with blunt oval to spindle-shaped nuclei and having fine fibrillary processes. And now we are going to talk about the last group, that is pediatric type diffuse high-grade gliomas. Diffuse midline glioma H3K27 altered. Diffuse midline gliomas or DMGs are characterized by loss of H3K27M, or more recent and accurate nomenclature is K28M, aberrant overexpression of EZHIP or EGFR mutation. Most DMGs are preferentially involved brainstem and pons. Patients usually present with a very short, less than 2-month duration neurological signs and symptoms. As expected, the prognosis is very poor with a 2-year survival rate of less than 10%. Tumor cells are usually small and monomorphic, however, polymorphous including astrocyte, oligodendroglial, epithelioid, or undifferentiated cells can be observed. Mitotic activity is often present. Microvascular proliferation and or necrosis may be observed but are not required for the diagnosis. Both antibodies H3K28M or K27M and H3K28M3 or K27M3 are crucial for diagnosis. DMG K27 altered cases display intense nuclear positivity for H3K28M along with loss of expression of H3K28M3. DMG K27 altered cases that are H3K28M negative may show intense nuclear staining for EZHIP. EGFR mutant DMG show loss of H3K27M3. Diffuse hemispheric glioma H3G34 mutant. It's characterized by missense mutation of the H33A gene. It's a highly cellular tumor with brisk mitotic activity having a glioblastoma-like pattern. Microvascular proliferation and necrosis are usually observed but not required for the diagnosis. Majority of the tumor cells are positive for nuclear P53 and negative for ATRX and OLIG2. Diffuse pediatric type high-grade glioma H3-wildtype and IDH-wildtype. It has 3 subtypes: diffuse pediatric type high-grade glioma, RTK2, RTK1, and MICN. RTK1 is enriched for PDGFR amplification. RTK2 is for EGFR amplification and TARC promoter mutation. MICN subtype for MICN amplification. Tumors associated with Lynch syndrome are typically of RTK1 subtype. Among the subtypes, RTK2 has a better median overall survival, whereas MICN subtype has a worst outcome. Morphology usually resembles of a glioblastoma or a primitive undifferentiated tumor. MICN subtype can have a biphasic pattern, including highly cellular circumscribed nodules and areas of diffuse infiltration. Infant type hemispheric glioma. This group of tumor is characterized by a typical receptor tyrosine kinase abnormality like fusion in an NTRK family genes or in ROS1, MIT1, or ALK. The tumor grade is yet to be assigned. Morphologically, these are highly cellular tumor with well demarcation and often involve the leptomeninges. High-grade features like mitotic activity, microvascular proliferation, and palisading necrosis are common.